Good morning. So I tried to go live a little bit earlier, but I was having trouble. And then because I didn't want to spend the bulk of my time playing with technology, really this morning is about getting the work done. Really don't have time to mess around with technology. So this morning I'm focused on getting through section six because it's a lot of text, it's a lot of content, and I'm going to get right through it. I have my coffee, I have my water, and I am going to sit here and read the entire section six of this lactation guide. Just a reminder that it's super, super important that you actually get the book. This is just a this is kind of like my own personal study guide so that I can read on the go, but also you need to have this book just so that you can reference it when you are supporting a family, but also when you are taking the assessments for your lactation certification, you will need the book. So, highly advise that you get the book. I have the details in this video. So, without further ado, section 6, breast and nipple issues. Ooh. Concern: history of breast surgery or injury. Descriptor: breast augmentation. Breast augmentation increases the chance of lactation insufficiency. The periareolar incision is most significantly associated with lactation insufficiency. Unique identifier: implants have been inserted into the breasts. Ask yourself, is there nipple sensation? Did the surgery alter sensation? Are the ducts patent? Are the nipple pores patent? Is there a history of changes in breast size and or appearance during pregnancy? Watch out for engorgement, breast binding, and tight bras that can decrease milk supply. Insufficient milk. What to do about it? Use tank tops with shelf bras, soft bras, or no bra for the first week or two to avoid pressure against the breast. Consider recommending milk expression to optimize production. Encourage report of the surgery to the pediatric healthcare provider. Expected resolution. Breast implants are not likely to have a negative effect on the breastfeeding outcome. What else to consider? Sometimes reassurance is needed about concerns that breastfeeding may harm the implants. This is not likely. Ask about breast surgery when in private. The partner and family members may not be aware of the surgery. People may not think of this procedure as surgery. We have come to ask them about breast improvements as well as surgery. In our opinion, it is important to have weekly or more frequent weight checks of the baby for the first months to ensure that there is adequate milk. Concern: history of breast surgery or injury. Descriptor: breast reduction. Breast reduction increases the chance of lactation insufficiency and may result in a decrease in the duration of exclusive and overall breastfeeding. Unique identifier: surgery has made the breast smaller. Ask yourself, is there sensation, especially down to the nipples? Did the surgery alter breast or nipple sensation? Are the ducts patent? Are the nipple pores patent? Was there any change in breast size and or appearance during pregnancy? Watch out for adequacy of ongoing milk supply. Milk volume may increase around the third day because of the change in hormones due to the delivery of the placenta. However, the nerves that convey sensation to the pituitary and signal adequate hormone release may have been severed or altered by surgery, and mature milk and ongoing production may not be sustained at an adequate level. Insufficient milk making tissue. Inability of milk to exit the breast because of severed ducts. Initial engorgement that does not resolve easily. This can be due to severed ducts and may further reduce milk production. What to do about it? Assessment and close follow up with frequent weight checks in the first month and beyond. Consider recommending milk expression to optimize production. Ensure adequate nutrition for the baby. Consider at-rest supplementation if supplementation is needed. Encourage report of the surgery to the pediatric healthcare provider. Expected resolution. There is no way to know ahead of time how much milk will be able to be made after breast reduction surgery. Frequent weight checks of the baby are mandatory throughout the first month and beyond. What else to consider? Ask about breast surgery in private. The partner and other family members may not be aware of the surgery. People may not think of this procedure as surgery. we have come to ask about breast improvements as well as surgery. In our opinion, it is important to have weekly or more frequent weight checks of the baby for the first month to ensure that there is adequate milk. Keep in mind, it sounds repetitive, but the first one was for breast augmentation, and then the second one was breast reduction. And so they have similar opinions and similar suggestions or recommendations. Concern: breast of dissimilar size. Descriptor: unilateral underdeveloped breasts. When breasts are markedly different in size and or shape, there may be adequate milk making tissue in one or both breasts. Unique identifier: the two breasts are markedly different in size and or shape. Ask yourself, have the breasts responded to the hormones of pregnancy? Are the Montgomery glands visible? Have the breasts increased in size or appearance during pregnancy? Watch out for adequacy of ongoing milk supply. What to do about it? Assessment and close follow-up with frequent weight checks for the first month and beyond. Ensure adequate nutrition for the baby. Consider if breast supplementation is needed. Encourage apprising the pediatric provider of the situation. Expected resolution: there is no way to know ahead of time how milk can be produced. Frequent weight checks are mandatory. In our opinion, sometimes the breast development may have been affected by chest tube placement before puberty or other surgical or traumatic changes to the chest. Concern: flat inverted nipple. Descriptor: flat nipple. Unique identifier: nipple appears level with surrounding tissue. Ask yourself, does the nipple evert, as in figure 6.1? Using the asymmetrical latch, the configuration of the nipple prior to latch is relatively unimportant. The concern is only if the nipple does not evert in the baby's mouth, because milk-making hormones may not be adequately released. I want to go to here's 6.1. 6.1, the everted nipple protrudes out from the areola. And so a lot of people think that that is like the perfect breast to breastfeed, but that's not necessarily true. Okay. Is this a flat appearing nipple as in figure 6.2 because it is stretched and occluded by breast engorgement or edema? Is this a new appearance for the nipple? Is the area around the nipple engorged? Is there pitting edema around the nipple? If the nipple was flat prior to the baby's birth, does the nipple respond to cold or tactile stimulation by becoming more evert? If so, the nipple should respond easily when stimulated during breastfeeding. Is the baby able to compress the areola and breast tissue and draw the nipple area into the mouth to form the teat? And so this is the flat nipple. It everts when cold or manually stimulated. So just because someone has a breast like this, that does not mean that they can't breastfeed it. Watch out for the misunderstanding that the baby latches only to the nipple. Rather, the baby forms a teat of the nipple areola and some breast tissue. Thinking that a nipple has to look like a bottle nipple in order to work. So that whole everted when the nipple's out, no, it's not necessary. Considering this to be a permanent situation, flat nipple epidemics that are a result of poor maternity breastfeeding management practices, e.g. muscle relaxants used during labor, enema from excess fluids during labor. Confusing flat with inverted nipples. Inverted nipples are drawn back into the breast. What to do about it? If the report is that the nipple was flat before the baby was born, assure the use of the asymmetric latch technique described in the section titled Normal Breastfeeding. It is especially important that the baby's bottom lip and jaw reach the breast first and that the latch is asymmetric. This makes the configuration of flat nipple unimportant. Document whether the nipple has everted during breastfeeding. We do this by standing behind the dyad during the feeding and observing the nipple at the moment of latch off. If the nipple is flat because the nipple is engulfed within milk-filled tissue, hand expression or engorgement relief is needed so that the area is soft enough for the baby to draw into the mouth. Then use the asymmetric latch. Expected resolution. Often, formerly flat nipples become everted over time with breastfeeding. Breastfeeding should not be a problem if flat nipples are managed appropriately. What else to consider? Although using a nipple shield may seem like a good solution for flat nipples, long term shield use may have negative ramifications for milk supply. I actually use a nipple shield because I had flat nipples, and my midwife gave it to me as a support. And it was the only thing that could help. But what was crazy was that when I couldn't find it, I would get so anxious about it. So think about this with your families about using the nipple shield and using it as a. It's supposed to be an aid, but it can also be detrimental to establishing a good latch. You really want to establish a good latch. The nipple shield is just a temporary tool. And so that was one of the first things. I remember a close friend of my mom's, she had come to visit me a couple of weeks postpartum, and I was so attached to the nipple shield. I had to get the nipple shield in order to feed my daughter. And she asked me, she said, "Well, when are you going to try? Do you want to try without the nipple shield?" And I was so scared. I was like, I can't do it without the nipple shield. I need the nipple shield. And so she sat with me and she helped me do it. But we struggled. But I think her asking me to try without it, it encouraged me to do it more and more without it. And then after a few weeks, we were good money. We got it. We were working synchronously and breastfeeding without the tool. So just consider when you are supporting your families that the nipple shield is just a temporary tool. It's not meant to substitute a good latch. So, okay, I forgot where I was. Let me just read. I'm going to read this again just to be sure. Concern flat inverted nipple, descriptor inverted nipple, unique identified nipple appears joined into the surrounding tissue as in figure 6.3. And figure 6.3, the caption says, the inverted nipple looks like a slit or a fold. The nipple should be graded by function, not appearance. Ask yourself, is this a nipple inverted by engorgement? Is this a new appearance for the nipple? Is the area around the nipple engorged? Is there a pitting edema around the nipple? If the nipple was inverted prior to the baby's birth, does the nipple respond to cold or tactile stimulation by becoming more erect? Is the baby able to compress the areola and breast tissue and draw the nipple area into the mouth to form the teat? What grade is the inverted nipple? Remember that the grading system is about function, not appearance. Grade 1 inverted nipples are easily pulled out by suckling or a breast pump. Grade 2 inverted nipples are easily pulled out by suckling or a breast pump, but don't maintain the projection once the baby's mouth leaves the nipple or the pump flange is removed. Grade 3 inverted nipples are difficult or impossible to pull out. Some think that this is because there are internal breast anomalies, such as short ducts associated with grade 3 nipples. Watch out for prenatal nipple manipulations are not effective for inverted nipples and may cause earlier cessation of breastfeeding than when prenatal nipple preparation is not suggested. So I hear a lot of families say that they use breast pumps to pull out their nipples, or they do a lot of nipples pulling out, like pulling their nipples before they start breastfeeding to kind of get in preparation, but that actually does not help, and you should tell your families not to do that. Confusing flat with inverted nipples. Inverted nipples are drawn back into the breast. Milk supply problems. Individuals with inverted nipples have been shown to have less milk and lower prolactin levels in research studies, and their babies have a higher risk of readmission for failure to thrive. What to do about it? Suggest the asymmetric latch technique described in a section titled Normal Breastfeeding. When the baby's bottom lip and jaw reach the breast first. One second. Breast first, the configuration of the nipple is less important. If the nipple ever everts, ask if the nipple ever everts. If so, is there a technique that has been used to draw out the nipple? Can this be done prior to latching the baby to the breast? This is this is different than before you even start breastfeeding or while you're pregnant, pre-stretching the nipple. This is different. This is like right before you start breastfeeding. You're about to put the baby to breast, stretching your nipple or preparing the nipple, which is very different. Document whether the nipple has everted during the breastfeeding. We do this by standing behind a dyad and observing the nipple at the moment of latch off. Dyad is the mom and the baby together. That's a dyad too, just in case you. I know that you've said that a couple of times in this book. Just wanted to say that again. Ensure adequate nutrition for the baby. Some babies will suck happily even though the nipple is not drawn out. Remember, calorically deprived babies often act sleepy and satisfied. Listen for frequent swallowing and assess milk transfer. So remember that suck, 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 swallow, suck, 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 swallow, suck, suck, swallow, suck, swallow, suck, swallow. You want to hear that and you want to see the baby's cheek. Make sure that they have a proper latch, because, and some babies may latch and mom will think that the baby is feeding and adequate, but actually if you observe, you'll notice that the baby is actually not pulling out milk. Encourage the report of this challenge to the pediatric healthcare provider to help assure close follow-up of baby's growth. Often, grade 1 and 2 nipples become everted over time with breastfeeding, hand expression, or pumping. In this situation, milk expression is needed as an adjunct to breastfeeding. With grade 3 nipples, there is very high risk of milk insufficiency and failure to thrive. Frequent weight checks and diaper checks and assessment of milk transfer are necessary. Provide close, ongoing pediatric follow-up to assess growth. What else to consider? Sometimes using a hard plastic breast shell inside the bra in between feedings has been reported to help to dry and evert the nipple. Using a nipple shield with inverted nipples may further reduce the milk supply and put the baby at increased risk for failure to thrive. If a shield is used, a milk expression plan is required to maintain milk supply. Calorically deprived babies act sleepy. So this is super important because we know in a lot of cultures, a sleeping baby is, oh, your baby is so well behaved, it's such a good baby, they sleep all the time, I have time to rest, I have time to do things. That is a red flag. An overly sleepy baby, you really need to make sure that the baby is actually getting the calories. If the baby's sleeping, then they're not eating. So making sure that they're getting the calories, not necessarily timing it, but making sure that they're getting 10 to 12 feedings a day. So calorically deprived babies act sleepy. The baby sleeping more and acting content is an ominous sign. Not a good baby sign, an ominous sign. Frequent weight checks are the only way to know how the baby is doing with breastfeeding if there is an inverted nipple. In our opinion, inverted nipples are related to failure to thrive and readmission for hyperatremic dehydration and malnutrition in the baby. Assessment of the breastfeeding, assessment of milk transfer, and frequent weight checks are necessary with inverted nipples, but are especially important with grade 3 inverted nipples. So these are all in the appendix. I'll go over the appendix at some point when we get there. But I guess there's a table there to assess, to help assess. Really, if you're a doula, you should be referring them to their medical provider. Concern: nipple pain while breastfeeding. Descriptor: nipple pain while the baby is latched on and actively nursing. Nipple pain may be common, but it is not normal. Any pain that is experienced should be thoroughly investigated. Nipple pain while the baby is actively feeding may be worse at the beginning of the nursing, continuous throughout the nursing, beginning in the first few days, beginning after there is abundant amount of milk, day 3 or 4 onward. Unique identifier: intense nipple pain that is worse at the beginning for the first minute or two and then subsides or continues at a lower level. Ask yourself, is the baby latching on suboptimally and then correcting his or her head or body position to accommodate a better flow of milk? Does a change in position or body motion coincide with a change in pain level? Watch out for baby head change, body movement, or other changes as the pain level decreases. What to do about it? Watch the baby nursing, paying close attention to the change in the baby's sucking, head position, and the breastfeeding posture the instant the pain level changes. Position the baby in the new, less painful position to begin the next feeding. Encourage attentiveness in positioning the baby in the pain-free posture. Expected resolution. Although there may be some residual pain for a day or so if the nipple has been damaged, the pain level should markedly decrease with more optimal positioning from the beginning of the feeding. What else to consider? Is there pressure during the feeding against the back of the baby's head? If so, this may cause the baby to pull back, stretching the nipple uncomfortably. Could it be that a pillow is changing the angle of the baby's head? In our opinion, nipple creams and other treatments will not fix this problem. In fact, the use of these commonly used preparations may discourage help seeking or working on corrective positioning interventions. So here's a table. There's a table here. And a table, I'll try to read it as I'm showing, but nipple pain. So here's a table of nipple pain. Pain is worse at the beginning of the feeding, and it directs you to some pages to look at that. Pain is continuous through the feeding. Pain is worse after the feeding. Pain happening during and after the feeding. Pain radiates towards the back. So this just shows you what page to quick reference. This is why they say, like, it's not meant to be read cover to cover. It's meant to be a quick reference when you're supporting families. Hey, if I have a question about this thing, I can go to the page. I actually might make a new tab here for pain. I have so many tabs here around, like weight loss, breast milk, how much breast milk, the appendix, but I actually should go to make another tab for nipple pain. I'm going to do that right now. If I can find my tabs. I always have dozens and dozens of tabs and sticky notes because that's how I take notes. Where are my tabs? Don't tell me I don't have my tabs. Or I use all my tabs. Alright, I'll just use these tabs. These are not the tabs that I wanted because the ones that I love to use, they're actually like plastic and flexi, and they're helpful because they're stronger than paper sticky notes. And I guess I use all of them, so let me just move on for the sake of time. Put a sticky here for pain. Yeah, can't find it. Okay. So yeah, all those nipple creams, should be very wary about the nipple creams because they may cause actually more infection. Really want to be careful. There may be a perception that by using the creams that you've solved the problem, but actually you may have inadvertently made the problem worse. Here they go. I love these stickies. I'm gonna take this off and put my favorite sticky on because these are legit. And they're super durable Post-its. I can leave my notes on them. They won't fall apart. They're not flimsy. Alright, let me just write this quickly. Pain. Most moms that I've had, families, they expect to be in pain. They expect the first latch to be painful, and I have to remind families that actually no, it should not be painful. There is no, it does not need to be painful. It may be a unique sensation, a different sensation, but it should never be painful. So, alright, now moving on. Concern. Nipple pain while breastfeeding. Descriptor: nipple pain while the baby is latched on and actively nursing. Nipple pain is common, but it is not normal. It is not normal. Any pain should be thoroughly investigated. Nipple pain while the baby is actively feeding may be worse at the beginning of the nursing, continuous throughout the nursing, beginning in the first few days, beginning after there is an abundant amount of milk, day 3 or 4 onward. Unique identifier: nipple pain that begins in the first few days and continues throughout the nursing. Nipple that is misshapen when the baby latches off. A compression line may be visible as in figure 6.5. Yes, I see this a lot in families, and I'm like, actually, this is why you observe the feeding and you observe the latch, and you have mom unlatch so that you look at the breast. And if you can see this misshapen, then you know that the latch is not correct. Nipple that is misshapen when the baby latches off. A compression line may be visible as in figure 6.5. The baby may spit up blood, tinged milk, or express milk is colored by small drops of blood. Ask yourself, did the soreness start before there was an abundant supply of milk? Is the nipple misshapen after the baby comes off the breast? If yes, consider suboptimal position of the baby at the breast. What to do about it? Assess the next breastfeed, including the pre-feeding behaviors, using the breastfeeding assessment criteria in Appendix B. Use corrective interventions to optimize the latching process and positioning for the feeding. If blood is seen, provide reassurance that the small amount of blood will not harm the baby. Expected resolution. Although there may be some residual pain for a day or so if the nipple has been damaged, the pain level should improve dramatically with more optimal positioning. If the baby has been positioned optimally, the nipple will not be misshapen after the baby latches off the breast. What else to consider? Correcting the position will markedly decrease the pain for more than 95% of dyads. A few babies exert higher than average amounts of pressure at the breast. The arrival of abundant milk flow may encourage some babies to increase pressure. Breast compress. So if the milk is flowing fast, they're going to be like this to like slow it down. And I had a lot of milk when I was breastfeeding. I had so much milk, so I know that like Bella, my daughter, was like, she had to clench down to slow down the flow of milk. And so that's something you need to watch out for. The arrival of abundant milk flow may encourage some babies to increase pressure. Breast compression or alternate massage may be used to increase milk flow and to diminish pressure. A nipple shield may seem like a good solution for nipple pain, but its use may increase the chance of milk insufficiency. It's best to work on assessment of the latch and suggesting corrective interventions. Research confirms that positioning the baby correctively is effective in diminishing pain for almost every mother. Concern: nipple pain while breastfeeding. Descriptor: oversupply. Nipple pain is common, but it is not normal. Nipple pain while the baby is actively feeding may be worse at the beginning, continuous, beginning during the first few days, beginning after there is an abundant amount of milk, day 3 or 4 onward. Unique identifier: nipple pain that begins after there is an abundant supply of milk and continues throughout each nursing. Nipple is misshapen when the baby latches off. This may be the constellation of factors called oversupply. Ask yourself, is the pain worse after the first few days? Is there an abundant supply of milk? Are there other signs of oversupply? Consider, sometimes the baby can manage the slower flow of colostrum but has trouble managing the abundant and rapid flow of milk after day 3 or 4. The pain may be related to the baby clamping down on the nipple because the flow of milk is too abundant or too rapid for the baby to handle. The problem of oversupply has a constellation of findings, including rapid weight gain of the baby and many large explosive bowel movements comes out of the diaper, along with the pain during feedings that usually is the reason for asking for help. The baby is often unstable after feeding and may spit up or vomit a quantity of milk. Consider that the baby is gaining well. The baby may still not act contented between feedings, giving the family the mistaken idea that there is not enough milk or there is something wrong with the milk. Weights taken before and after nursing with a digital scale accurate to 2 grams show rapid transfer of more than expected amounts of milk at the breast in a shorter than expected amount of time. For example, 3 ounces in 5 minutes in a baby under 1 month of age. So basically, you can find out if the baby's getting too much milk by weighing before and after the feeding. What to do about it? Help with achieving a posture in which the baby is able to move his or her head freely when the flow of milk is too great or too fast to handle. One posture that works well is reclining or semi-reclining, and the baby's body is supported chest to chest. See figure 6.6. So, baby reclining. The reclining or semi-reclining posture. Is in this posture, the baby no longer has to work against the milk flow. More aggressive treatment may include nursing on only one breast at each feeding to allow a small amount of breast compression to tamp back the supply. A firm but not overly tight bra may also help. Counsel against too much pressure that could foster mastitis. See also Appendix K. Massive oversupply may respond to nursing on the same breast for 2 or more feedings in a row. Again, watch for plugged ducts and mastitis. See also Appendix K. Instead of decreasing the milk supply using compression, some prefer to collect the extra milk and donate to a milk bank. Expected resolution. Although there may be some residual pain for a day or so if the nipple has been damaged, the pain level should decrease with the baby in control of the flow rather than overwhelmed by it. The nipple should not be distorted after nursing. What else to consider? Excessive hand expression or pumping to get rid of the extra milk may compound the problem by relieving the compression on the cells. As a result, the milk supply continues to increase. So more pumping and more extracting milk is just going to cause you to create more milk. So that may not be what you want to do. In our opinion, for many years, poor breastfeeding management practices highlighted the issue of not enough breast milk. We think that the constellation of oversupply of breast milk is increasingly common as more and more families choose to breastfeed exclusively and for longer durations. It seems to be more likely to happen with second or subsequent breastfed babies. Concern: nipple and breast pain after breastfeeding. Descriptor: Raynaud's phenomenon, vasospasm of the nipple. Nipple pain is common, but it is not normal. Any nipple pain should be investigated thoroughly. Unique identifier: excruciating nipple and breast pain after nursing and at other times when the nipple is cold or wet. Always accompanied by nipple color change, a waxy white, quickly transient to cyanotic blue or gray, and then the raspberry pink or white to pink. Often the areola changes shape at the same time. So I don't know what this looks like on black women, actually. And I should Google it to see because, a lot of times these references, they are on white or fair-skinned women, and it's hard for brown-skinned or dark-skinned women to see if they, have these same symptoms. Often the areola changes shape at the same time. Pain is worse after the nursing pumping hand expression. Although the greatest amount of pain is described to be near the nipple, pain may radiate throughout the breast. Pain also occurs when the nipples are cold and or wet, when getting out of the shower, for example. The pain is excruciating, may be described as burning or stabbing. Consider that what is being described may indicate nipple vasospasm or Raynaud's phenomenon of the nipple. So just know that Raynaud's phenomenon is extreme bodily response to cold or wet, and it's like pain. It's excruciating pain to cold or wet. And I think that's what they call a unicorn. Ask yourself, does the nipple change colors from being lighter to pinker and more blue or gray? The skin may even look white and waxy. Do the color changes happen along with pain seconds to minutes after the baby comes off the breast, after pumping, after showering, when cold and wet? Is the pain related to the nipple changing from being warm to being cold? Does drying, warming the nipple and breast decrease the pain? Watch out for confusing this with yeast, Candida albicans, and problems. Nipples do not show the multiple color change if the problem is yeast, and white patches would be seen in the baby's mouth. Also, if the problem is yeast, the pain is usually described as burning both during and after the feeding. Confusing Raynaud's phenomenon with the appearance of white or gray stripes or areas on the nipple that are visible immediately after feeding, caused by compression of the nipple that has not been properly placed in the baby's mouth during the feeding. While pain is experienced in this case as well, it is typically present throughout the feeding as well. In the case of whitening graying caused by compression, improving the latch will stop the compression and thus alleviate this problem. What to do about it? Ensure optimal positioning. Eliminate any other causes of painful nipples that can contribute to nipple pain. Sometimes it works to keep warm clothes nearby to warm the nipple after feeding so that the nipple cools more slowly. Nifedipine has been prescribed for nursing mothers with Raynaud's symptoms of the nipples with good results. Remember, as a doula, you are not prescribing any medication. You're not recommending any medication. This is just FYI. If you are practicing a provider, you need to really refer this out to a medical practitioner so that they can do further observation and prescribe any medications as needed. You, as a doula, are not prescribing any medications. Expected resolution. Some report as a marked reduction in pain once the trigger factor for nipple vasospasm has been addressed, but nifedipine may also be considered by the healthcare provider. In our experience, with nifedipine being prescribed in this situation, it may take several days of treatment for the pain to resolve completely, and the color changes may persist even when the pain has subsided. What else to consider? Raynaud's could have been an issue before pregnancy and breastfeeding, but it can happen after suboptimal positioning, high mouth pressure during suck, nipple infection, eczema, and other breast and nipple conditions. Each possibility should be considered. In our opinion, we have seen cases where Raynaud's symptoms of the nipples began in the early teens. Often there is a family history of Raynaud's. We were told about one situation where Raynaud's wasn't diagnosed until breastfeeding. The mother told us that she was surprised that anyone liked to swim because she assumed that everybody had the same painful nipples that she did after swimming. We have also seen the development of Raynaud's after a long course of painful and infected nipples. Concern: nipple breast pain while breastfeeding and continuing after and between feedings. Descriptor: Candida albicans, yeast or thrush unique identifier. Burning pain during and after breastfeeding. Shiny, flaky skin is visible on the nipple and areola in many cases. In addition, white patches are seen in the baby's mouth, inside the cheeks, and on the tongue. The baby's diaper area may also have a yeast rash. Ask yourself, has the baby had antibiotic treatment that would predispose him or her to C. albicans overgrowth? Are the positioning and latch optimal? Watch out for overdiagnosis of yeast as the cause of sore nipples without consideration of other possibilities. Thinking that there was yeast inside the breast. Researchers have found no C. albicans in the milk of women with deep breast pain and suggest that it does not migrate into the breast. What to do about it? Both members of the dyad and any vectors must be treated. Vectors can include breast pump parts, pacifiers, spot on nipples, and any other object that can harbor C. albicans. In some cases, another family member may harbor C. albicans. Treatment is only effective when the vector has also been eliminated. A variety of treatments are also available to prescribe for both members of the dyad. For example, the oral suspension Nystatin may be carefully applied inside the baby's mouth, being sure to coat all surfaces. Excuse me. Nystatin may also be applied to the nipple areola and the baby's mouth. Fluconazole, an oral medication used to treat C. albicans, may be prescribed for both members of the dyad. Again, doulas, this is FYI only. You are not prescribing medication. In addition, breast pump parts, washable breast pads, bras, and other possible vectors should be carefully cleaned. Washing with hot soapy water is important. For fabrics, washing in hot water and drying in a hot dryer is recommended. Some also recommend adding vinegar to the wash or final rinse. Some vectors, such as pacifiers, have too much biofilm that can't be removed easily and should probably be discarded. So, yeah, pacifiers, they carry a lot of germs and they carry a lot of, just like as it says, biofilm and yeast. Just get rid of it. Just get rid of it. Expected resolution. If the treatment is effective and vectors are effectively cleaned, relief should be felt in 1 or 2 days, although it may take 5 to 14 days to finish prescriptions. What else to consider? Deep radiating breast pain is more likely to be related to a bacterial than a fungal infection. Research indicates that the breast discomfort may be a reaction to contact with the yeast in the baby's mouth, not a yeast infection. Careful use of an antihistamine has proven to be effective in this case. There is concern about yeast in stored frozen milk. Freezing does not kill yeast. This is less of a concern for older, healthy babies than it is for premature, fragile, or ill babies. In our opinion, we have seen many cases at the Center for Breastfeeding with the complaint of persistent cases of breast and nipple yeast without symptoms in the baby. The problem in virtually every one of these cases was actually suboptimal latch and positioning. Yeast treatments have been instituted without a careful evaluation of latch and positioning. The yeast treatments were thought to be ineffective or the yeast was drug resistant because the soreness did not lessen. Always assess latch on and positioning, even in cases where visible yeast is present in the baby's mouth. Concern. Nipple pain that radiates through the breast and even to the back. Descriptor, bleb, sometimes inaccurately called a milk blister. Unique identifier, a firm, small white spot or bleb or duct block near the nipple pore opening of accumulated milk solids visible on the nipple face. Sometimes the nipple itself may be distended, especially if there are multiple blocked nipple pores. Occasionally, nipple skin grows over the bleb and prevents the bleb's removal without lancing. Lancing is like when they poke the needle in and express. Nipple pain is experienced while the baby is latched on and actively nursing as well as in between feedings. Pain usually also increases when anything such as clothing touches the breast and radiates from the nipple tip toward the spine. Ask yourself, can the baby extract the retained milk with more effective feeding? Is this a milk blister from friction? In which case, a breastfeeding assessment may determine if a change in latch can reduce friction, which is the cause of the blister. Does the baby have a blister on his or her lip, which may also indicate that this is a milk blister due to friction, not a bleb? Watch out for reoccurrence if the underlying problem is not addressed. The development of some systemic symptoms, fever, malaise, that may indicate onset of mastitis. What to do about it? Work to achieve a more effective position. Will soaking the breast in warm water prior to nursing or hand expression help to loosen the bleb? Will gentle hand expression and finger manipulation expel the bleb? Has skin or a clear layer of tissue accumulated over the bleb? Is that the reason the bleb is not moving out of the nipple? In some cases, lancing followed by expression of the retained milk is the only way to solve the problem. The milk behind the bleb is usually thick, the consistency of soft and cream cheese. A few drops of blood are not unusual after lancing. Why did the bleb form? Is part of the breast draining poorly? Tight bra, underwire, binding, other constriction on milk flow, bruise? Was there a plug duct further up in the breast prior to the bleb forming? Expected resolution. Once the bleb and the milk behind it are removed, the pain should decrease markedly. What else to consider? Plugged ducts and mastitis. And the mastitis will have systemic symptoms. In our opinion, no one really understands why blebs happen. There are reports of repetitive cases of plugged ducts or blebs being decreased in incidence with an increase in the amount of lecithin in the diet. We have known cases where this has worked. Let's see. Concern, swollen, painful breast. Descriptor, engorgement. Unique identifier, painful, swollen breasts as in figure 6-7. Often occur between days 2 and 4 after birth or later if the baby was born by a cesarean section. This can also happen anytime in the early weeks if the baby is not feeding often or effectively enough. Ask yourself, is the baby feeding frequently and efficiently enough? Appendices B and E. Oh. So here's the caption. When the breasts are engorged, they are hard and hot. The skin may also be so stretched that it is shiny. So shiny, red, hot. That's the signs of engorgement. Ask yourself, is the baby positioned well at the breast? Is there a mild fever without an area of redness on the breast? Watch out for redness, malaise, flu-like symptoms, signs of mastitis. What to do about it? Increase frequency and efficiency of feedings. Relieve pressure and pain by allowing excess milk to flow out of the breast. Water is a wonderful aid. Either the shower or bath or breast water baths, as in figure 6-8, may help the milk flow and relieve compression. So this is a breast bath. You just put a bowl of lukewarm or water, and you dip the breasts in the water. Just let the breasts hang, and let the milk kind of come out, and that should help. That can help with engorgement. Or a shower. Most are recommended a shower, but this helps a lot. I've heard a lot of doulas and lactation consultants and midwives say that dipping the breast in a bowl, like hanging your breast over a bowl of water, helps. And then the caption here says lukewarm water, in this case in a dishpan, helps to relieve engorgement by encouraging milk to flow. Okay. The baby should be allowed to nurse until he or she comes off spontaneously. If the baby is not interested in taking the second breast at that feeding, offer that breast first the next time cues are seen, often with a half hour in the first days. Gentle expression may also relieve pressure. Consider mild analgesics, especially if they are non-steroidal, anti-inflammatory, and NSAIDs medications. Expected resolution: improve frequency and efficiency of feedings, along with relief of some pressure, should decrease the pain and discomfort within hours. It may take a few days for the engorgement to completely resolve. What else to consider? The natural swelling in the breast beginning on days 2 through 4 is not only because of accumulated milk. There is an increased amount of blood and lymph that will resolve as the days pass. Suboptimal breastfeeding increases the amount of milk remaining in the breast after a feeding, leading to engorgement. Normal fullness without high levels of pain and discomfort is almost universally experienced after birth, whether or not breastfeeding is planned. Evidence-based review of the literature does not support either warm or cold application as the superior choice in the relief of engorgement. Either may provide relief. Individualized comfort measures based on personal preference and cultural belief. Exposure to cold during the postpartum period is not considered helpful in many cultures. So like the warming, there's a lot of cultures in postpartum of warming and keeping warm. So cold is not necessarily a thing. And so you just need to be aware of the culture that you are serving and what they consider a good postpartum practice. Does not support the use of cabbage leaves or cabbage salves over cool gel packs or other comfort measures for reducing pain and engorgement. The best possible method to reduce engorgement is to keep the milk flowing and the baby nursing effectively. Save your cabbage for your rice and peas and your jerk chicken. Save it to eat it. Don't put it on the breast because it's not more effective as just a plain cold compress. In our opinion, we have seen rare cases where the engorgement resolves in only one breast. The other continues to be swollen with pitting edema. This does not seem to be an issue with milk, but rather with lymph drainage. Techniques to promote lymph drainage, e.g. exercise massage, have been helpful in the successful resolution of this residual swelling. Concern: breast lumps. Descriptor: plug duct, also called clogged duct or cake breast. Unique identifier: hard, often painful area of the breast, swollen, plugged, or clogged with milk because of temporarily poor milk drainage with no systemic symptoms. Ask yourself, how can positioning and milk transfer be improved? Watch out for: are there any systemic symptoms, e.g., fever, malaise? If they are present, consider that this could be mastitis. If the skin over the hard, painful area is the skin over the hard, painful area reddened? Again, consider that this could be mastitis. What to do about it? Solicit an accurate description of the plug's location. For example, right breast 11 o'clock, forefinger widths from the base of the nipple. That way, it can be documented how the lump has moved. Encourage starting on the side of the plug to maximize flow when the baby's suckling is the most efficient. Change posture and the baby's body position. Changing position at the breast may allow the plug to exit the breast. There are many reports that changing position so the baby's chin points in another direction at the breast was helpful. Light massage during breastfeeding on the affected side may increase milk flow. Expected resolution. The plug should move toward the nipple with each feeding and disappear within 24 to 48 hours. Tenderness in the area of the lump may be reported for several days after the lump has moved. The lump may come out as stringy milk or a hardened blob of milk. This is not harmful. This is not harmful for the baby to consume. If the lump does not move in 24 to 48 hours, a referral to an appropriate healthcare provider must be assured. So observe for that 24 to 48 hours, it should move. If not, refer out. Occasionally, dried milk solids lodge in the nipple as blebs. What else to consider? And it says see more about blebs on pages 66 and 67. And so here's where, this is where the book comes in handy. You're going to need to have it so that you can flip back and forth. What else to consider? Lumps in the breast can have many other causes. If the plugs do not move out in 24 to 48 hours, a physical exam by a qualified healthcare provider is required. In our opinion, blocked ducts tend to happen when the breast is not draining as well as it should. Careful assessment of a feeding and examination of possible items such as bras, seatbelts, baby carriers, bags, which can create compression on the breast, can help determine the underlying reason for the development of the plug, and correction may serve to prevent or minimize future plugs. Concern: reddened area of breast with systemic symptoms. Descriptor: mastitis. Unique identifier: sudden illness with flu-like symptoms and a painful, hard, reddened area on one breast. Mastitis always indicates inflammation in the breast and may be either infective or non-infective. Ask yourself, could the illness be caused by something besides mastitis? Other causes for the symptoms should be considered. Watch out for: are both breasts reddened with fever and flu-like symptoms? If so, this is a potential medical emergency, e.g. strep infection, for which care should be sought urgently. Mastitis that is not treated promptly and effectively may result in abscess. What to do about it? Mastitis may be infective or non-infective, but it always indicates an inflammatory process. Non-steroidal anti-inflammatory medications should be considered. If improved breastfeeding practices and NSAID medications do not resolve the symptoms, or if the symptoms become worse in a few hours, consider a course of antibiotics if infection is suspected, e.g. if there are nipple fissures or signs of nipple damage. Staphylococcus aureus is the most likely organism cultured in cases of infective mastitis, although a variety of other organisms have been implicated. Think about the cause of mastitis and how to decrease the chance of mastitis recurring. Predictive factors for mastitis may include ineffective hurried feedings, plugged ducts, suboptimal feedings, tight bra, underwire bra, or pressure on the breast, nipple damage, anemia, especially if mastitis is recurrent, use of breast shell inside the bra between feedings, or nipple shield during feedings, short lingual frenulum or tongue-tied baby. Asterisk on the tongue-tied, and you probably will when you are taking the course. There's been, I think that the evidence is inconclusive about this tongue tie, getting the tongue tie cut. So definitely read up more on that and the efficacy of cutting the tongue tie. Help the family think about caretaking during this time. Bed rest, fever reduction, and NSAIDs are and improving breastfeeding practices should be considered along with breastfeeding frequently. Mastitis, even infective mastitis, does not require breastfeeding suspension or cessation. So you don't have to stop breastfeeding if mastitis is seen or suspected. Expected resolution. Symptoms should resolve in 5 days, usually before the prescribed antibiotic is finished. Encourage continuing the antibiotic if prescribed, even after the symptoms resolve. What else to consider? Anemia in the case of recurrent mastitis, inflammatory breast cancer. In our opinion, mastitis is often accompanied by a feeling people describe as being run over by a truck. Prompt medical attention, rest, and appropriate changes to breastfeeding practices result in speedy recovery for most. There is no need to interrupt breastfeeding. Breast cancer diagnosis, especially diagnosis of inflammatory breast cancer, may be delayed during breastfeeding because of the mistaken diagnosis of recurrent mastitis. Breast cancer, including inflammatory breast cancer and Paget's disease of the breast, have been diagnosed in the population of lactation individuals. People with recurrent mastitis should be referred to their healthcare provider for thorough medical evaluation. Concern: breast lump with flu-like symptoms. Descriptor: abscess. Unique identifier: pus-filled lump in the breast that does not move. Abscess is often associated with continuation of mastitis symptoms after 5 days of appropriate antibiotic treatment, but may occur without a history of mastitis. The affected area of the breast is usually tender. Ask yourself, is the tender lump milk or pus? Needle aspiration is needed to confirm the diagnosis. The worst solution is to stop breastfeeding milk expression altogether, or even stopping only on the affected side. Suddenly stopping breastfeeding will make the problem worse. Engorgement will become part of the problem. If the choice is made to dry up on the affected breast, it should be done slowly. Pus may drain out through the nipple. This will release some of the pressure, but does not preclude medical treatment. Do not put pressure on a draining abscess. There is a possibility of methicillin-resistant Staphylococcus aureus MRSA infection in the abscess. This appears to be on the rise. What to do about it? Refer to obstetric care provider. Refer. Who can assess the need for evaluation for an abscess? Usually, diagnosis is confirmed by needle aspiration of pus. Ultrasound may indicate fluid, but may not sufficiently differentiate between abscess and galactocele. Draining of the abscess. Repeated needle aspiration is sometimes needed. Drain or drains insertion ultrasound to guide the placement reduces the need for surgical placement of a drain. Any entry into the breast should be made as far away from the nipple and areola as possible, and cutting across the duct should be avoided. Antibiotic therapy and non-steroidal anti-inflammatory fever-reducing medications. Again, for doulas, this is just FYI. You're not diagnosing, you are referring out. That is your first line of action. After diagnosis and treatment, recommended bed rest and continue breastfeeding on the unaffected side. Encourage continued breastfeeding on the affected side if possible. If putting the baby to breast is not possible, hand expression or gentle pumping should be recommended to remove milk. Assess breastfeeding and ensure that any pressure on the breast that might hinder milk flow is removed. The abscess will be drained, and if there has been an incision, the area healed. Breastfeeding can definitely continue on an unaffected breast, and at a minimum, milk supply should be maintained until the baby can return to the breast that has the abscess. What else to consider? A galactocele or breast cancer. In our opinion, abscesses happen rarely, but they are usually the result of untreated or inadequately treated plugged ducts or mastitis. And that is the end of section 6. We did it. I sat here diligently and read the section. It was very challenging for me. I hope that this was helpful to you, and I will be back for section 7, which it seems to be about a little bit less than 20 pages, but it's going to be another long one. So another time where I'm going to have to be super diligent. I think the longest section is section 8, and so I'm bracing myself for section 8. The section 8 may very well be a 2-hour read. Yeah, it's going to be one of those. But I will brace myself for that. I'm going to get up super early probably for that one and read through that just because I want to get it done. But the beauty is that, okay, section 9 is relatively short. And then after section 9, then we have all the appendix, the lactation terminology, and, we will get through this. We will definitely get through this. So I thank you for joining me, and I hope that this was helpful. Bye.